So good morning. Welcome to Grand Rounds. I'm John Hiddelman, the Division Head of Gastroenterology. And the reason I'm up here is because I'm introducing our Wade Vollweiler lecturer, Dr. Anna Law. First, a few things about Wade Vollweiler. He was the first Division Head of Gastroenterology and was the Division Head for 33 years, which is a remarkable feat. I'm very happy to have been able to inherit his division, and on that infrastructure he built, and we certainly hope to build and make him proud. I'd like to introduce Anna, who's a colleague and friend of mine. Anna did her medical training at the University of Hong Kong and her fellowship in hepatology at Royal Free Hospital in London, United Kingdom, and worked with Sheila Sherlock, who to this point has really been the godfather, godmother of all liver disease, really quite a figure in research and teaching in liver disease. Anna also did a postdoctoral fellowship in molecular biology at UCSF with Harold Varmus, and was at the faculty of the University of Hong Kong and the Royal Free Hospital in the UK, and then came to the U.S., recruited to Tulane University, and then was recruited to University of Michigan in 1995 as a full professor, where she remains as the Director of Clinical Hepatology, Associate Chair for Clinical Research, and the Alice Andrews Research Endowed Professor in Hepatology. Her research interests include the natural history and treatment of Hep B, and we're going to hear about Hep B this morning. This evening, she'll be speaking at the Pacific Northwest GI Society, a little plug for that, and another one of her research interests, which is the emerging therapies for hepatitis C, including getting rid of all those nasty side effects from interferon. So certainly you're welcome to join us at our evening event, and she'll talk tomorrow also about the research kinds of advances she's made in hepatitis B at our GI Grand Rounds tomorrow morning at 7:30. Her current funding is vast. One thing that I'd like to point out is Anna is a wonderful organizer of people and a great collaborator. If you look at her CV, you'll see that she has collaborated with literally hundreds of people across the globe, and she has this great knack of being able to get people to work together and play nicely in the sandbox, and that's why she's director of so many things, such as the Hep B Research Network, and also the Living-Related Donor Liver Transplant Network. She has, over 300 original peer-reviewed publications, in addition to about 150 reviews. And these publications are in our prestigious journals such as Gut, Cancer, Hepatology, and the New England Journal of Medicine. She's got a ton of awards. The ones that I really like were she's a fellow of the Royal College of Physicians in Edinburgh. She achieved the Distinguished Achievement in Clinical Research Award from our American Digestive Health Foundation, received the Outstanding Woman in Science Award from the American Gastroenterological Association, and the Distinguished Service Award from the American Association for the Study of Liver Disease. She's on the governing board of that organization, which is our premier liver disease organization, and will be the president in 2017. She's been invited to be a speaker at literally hundreds of international meetings, and we're very honored to have her speak today, today's grand round topic, which is the emerging management of chronic hepatitis B infection. So please help me welcome Dr. Anna Law.
Well, thank you very much, John, for the kind introduction. It's great to be here and to be among friends. And it's a particular honor to be giving this talk in honor of the first division chief of gastroenterology here. And I noticed that he was also involved in the ASLD. So when I try to figure out what I'm going to talk about, I thought that most people are going to want to hear about hepatitis C. But I was specifically told that I have to talk about hepatitis C tonight. So I thought I would talk about a slightly different topic. This is my disclosures. I started my career, as John mentioned, in Hong Kong. And I did my hepatology training in London. That was back in the 1980s. There was no hepatitis C. We call it non-A, non-B. And fatty liver wasn't a big thing because we were all leaner and probably walking a lot more. So focusing on hepatitis B was just a very natural choice for a career focus. After having been on faculty at University of Hong Kong for a number of years, I realized that I reached a point where I need to look for other ventures. And I decided to move to the US. When I moved to the US, first of all, because I had never had any training in the US, some people said, "Are you sure you're going to make it?" Well, maybe. I said, "Look, don't worry. The worst is I go back to Hong Kong, I go into private practice, and I'll be rich." So if that's your worst alternative, it's really not so daunting. But in choosing an academic focus, people say, "So you're going to pick a different focus, right? Because there's no hepatitis B in the US. And with vaccination, it's just going to be gone. And pretty much, this is an ancient disease. Everything that we know, we pretty much know already. What's more to study?" So would a research career focused on hepatitis B be sustainable? And as you witness, I'm still employed, so that isn't so bad. So what I'm going to do is discuss with you some of the progress that we've made in the last 30 years. And obviously, I want to convince you that I don't need to retire today because there's still work to do. So we'll talk about declining incidence of hepatitis B infection, that the hepatitis B vaccine is the first vaccine demonstrated to prevent cancers. It's actually before the papillomavirus vaccine. We'll talk about natural history and how we develop predictive models for adverse outcomes and what treatment can do now and what we need in the future. So many of you have heard about the CDC touting that, look, we've done a wonderful job. There's been a dramatic decline in the incidence of new cases of acute hepatitis B. So the graph shows a decrease by 90% between the 1980s to now. And the number of cases reported is obviously a tip of the iceberg because there are many cases that are not truly reported. But when you start looking at prevalence of those who are chronically infected, you see that this is based on an NHANES study, that the drop is only by 20% and not by 90%. And the drop is mostly in children and adolescents, but not as marked in the adults. So why is that the case? Well, if I look around in this room and I ask how many of you are real Americans that you were born here and your parents were born here, there will be very few of you because this is a melting pot. And this is what CDC now figure out. Well, the reason why the prevalence of chronic hepatitis B is not going down is because we get a lot of these chronic hepatitis B that are imported in quotation. Essentially, these are people who were born in countries where hepatitis B is common. They were infected in their home countries before they come here. So that really hasn't declined. The number of patients who were infected in the US and who then go on to chronic infection has dramatically decreased. And this is just one slide from the Hepatitis B Research Network that John mentioned about. For more than 10 years, I've been petitioning the NIH to support a clinical research network on hepatitis B, and we finally succeeded in 2008. There was some setup. We had 21 centers in UW with Bob Griffiths as one of these sites. So there are 21 centers in the US and one in Canada in Toronto. So this just show the initial cohort of patients that we enrolled, more than 1,600 people. And this is just looking at where they come from. 82% of them were born outside North America. The biggest part is from Asia. Actually, there was only 3 from Australia, so we lump it together. And there's a pretty sizable number from Africa as well. Now, why is this important? Because 10 years ago, I published a paper in Gastroenterology looking at the distribution of hepatitis B virus genotypes in the US. People thought that, some people who weren't waking up thought that Americans come from Europe. Well, that was a long time ago. And therefore, the hepatitis B genotype should reflect the prevalent types in Europe, and it will be mostly A and D. But obviously, this is now telling us this is the biggest pie. And these people are infected with the genotypes prevalent in Asia, which is mostly B and C. But if you look at the people who were born in Africa and who came to the United States, they're mostly A and E. And that's reflective of the common ones in that part of the world. In Europe, yes, it's mostly A and D. And even if you look at people who were born in the US, many of them were actually born to Asian parents. So B and C was common as well. But why is it important? It is important because we now know that HBV genotypes can influence disease progression. For example, liver cancer is more commonly associated with genotype C and to some extent genotype F. Genotypes are also related to how long it takes for you to achieve E antigen seroconversion. It also impacts response to interferon therapy. So knowing which strain of virus the patients are infected with and which strains are more common does make an impact in our understanding of the natural history as well as management. So let's sort of, okay, we have all these people coming from different parts of the world. But you say, don't we have the hepatitis B vaccine? Aren't people in other parts of the world getting vaccinated so that there should be less hepatitis B infection in those parts of the world, and eventually it doesn't matter where they come from? Well, it is true the hepatitis B vaccine was first licensed in 1981, so it's been a long time ago. And as of from 2012, 94% of the UN member states have initiated a hepatitis B vaccination program, with an average of 79% of those getting a third dose vaccine coverage among the infants. So it is coming down, but not fast enough. And the overall prevalence of chronic hepatitis B infection worldwide, estimated by WHO and CDC, has only decreased from 4.2% in 1990 to 3.7% in 2005. So not decreasing fast enough, largely because among the adults, there's nothing that you can do. They were already infected, so the impact can only be on the younger people. But as I've mentioned earlier, hepatitis B vaccine not only prevents hepatitis B infection, but also decreases the incidence of hepatocellular carcinoma. And the best example is really provided by Taiwan, the first country in the world to implement universal vaccination of all newborns. So this was implemented in 1984, and you can see the prevalence of chronic hepatitis B infection decreasing dramatically from about 10% in 1984 to less than 1% in 2004. But more strikingly, they also show that there is a decrease in mortality from chronic liver disease, particularly among men. So people who were born before the vaccination era, the mortality from chronic liver disease would be about 3 per 100,000, dropping to only about 1.2. Similarly, there's been a dramatic drop in hepatocellular carcinoma incidence as well as mortality from hepatocellular carcinoma. And this is really mostly among children, adolescents, and you can see that in another 10, 20 years, we'll also see the impact in adults as well. But it's not all rosy. There's always glass half full and a glass half empty. When we say that 94% of UN member states have initiated a vaccine program, it means that 6% have not. And it's not because of lack of resources. And pardon if I am offending someone, is really ignorance and perhaps a little stupidity that some of the wealthy countries in the world who can afford to implement vaccination programs are not doing so because they believe that infection is somewhere else. They don't come here. And all of us have been hearing about Ebola on and on all the day now the last few days. So it's not just in West Africa, it can come here. So to actually say that we don't need a vaccination program is very arrogant. But there's also another problem. With hepatitis B, the risk of going from acute to chronic infection is the highest if you get infected as a baby. If you get infected as an adult, majority of us, our immune system is able to get rid of the virus and doesn't go into chronic. So vaccinating babies at the time of birth is the most important in preventing chronic infection. Many of the resource-limited countries cannot afford to purchase the vaccine, and they rely on NGOs, the non-government organizations, to help, one of which is the Gavi, that the Gates Foundation put a lot of money into, and the Global Alliance for Vaccines and Immunizations. Unfortunately, they have decided that they would not cover the monovalent hepatitis B vaccine so that babies cannot get birth dose vaccine. They have to wait until they're 2 months old when they get hepatitis B vaccine as part of pentavalent vaccine with the tetanus, diphtheria, and all that stuff. So that can be a problem because between 0 and 2 months, they can be exposed and they can be infected, and if they happen to be infected, they can go into chronic infection. And yes, I've told you that the WHO estimates that the global prevalence of chronic hepatitis B dropped from 4.2% to 3.7%. But because the world's population has grown, the denominator has increased. So actually the absolute number of people has increased slightly, from 223 million in 1990 to 240 million in 2005. And chronic hepatitis B infection still accounts for about 600,000 to 700,000 deaths annually, and is responsible for about 70% of liver cancers worldwide. So we've got to do something. We've got to really be able, when we see patients in clinic, know, is this someone that is going to go on to adverse outcomes, cirrhosis, liver failure, liver cancer, so that we can focus more of our attention on those folks. And there's been a lot of work in that area in the last 10 years. So one of the tricky things with chronic hepatitis B is that it doesn't actually go through stepwise deterioration. It has some spurts and then periods of quiescence. And you've got to really catch what is going on. So this is how we depict the chronic hepatitis B infection as being divided into 4 different stages. Many people argue about it, but it's a very useful concept. So the first stage in general we call it immune tolerant, and I just came back from a meeting and the immunologist said, stop using that term if you don't know what it means. There's some discussion. We're going to come up with new terminology that reflects our better understanding of what actually goes on. But be that as it may, in this phase, patients are antigen positive with extremely high levels of DNA and usually normal liver enzymes. The typical patients are the young Asian patients infected perinatally, and they have a ton of virus but very little injury. Then later on in life, it's just as if the immune system starts waking up and it starts to attack the infected liver cells. So you start to see the liver enzymes go up and the virus DNA may come down. Some patients are very lucky and it's just one smooth transition and they seroconvert from E antigen to anti-E. But some people go through a lot of flares, and during this period of time, they may acquire a lot of liver damage. After seroconversion, some patients go into what we call the inactive carrier state. The DNA, the virus is still there. We know the virus is still there because if you actually immunosuppress them, the virus will spring back to life. And the liver enzymes become normal. But at a later stage, it can become reactivated again. Even though these patients remain E antigen negative, and we now recognize that many of these patients, the virus has undergone a mutation in the pre-core or the core promoter region that stop the production of E antigen, but the virus can continue to replicate. So clinically, it is challenging because we know that among patients with chronic hepatitis B infection, they may have chronic hepatitis, they may be in an inactive carrier state, and they may go from one state to another during their lifetime. But we know that one of the dire consequences of chronic hepatitis B is that it can progress to cirrhosis and hepatocellular carcinoma. But unlike hepatitis C, where cirrhosis is usually an intermediate step to cancer, with hepatitis B, you can actually have cancer without going through cirrhosis. And this is in part because the hepatitis B virus can integrate into the host genome, causing changes. So one of the things that we've learned a lot in the last 10 years about pathogenesis of hepatitis B-related liver disease is that the virus does matter. When I was a student, I was taught that, well, hepatitis B virus is not a cytopathic virus. Liver injury is immune-mediated. And to some extent, this is still true, because if you look at renal dialysis patients, for example, they tend to always have normal liver enzymes, no matter how high the virus level is, because they're immunosuppressed. But we have now learned that, of course, the virus matters. If there's no virus, there's no disease. But the virus may have more direct effects than we imagine. And one of the things that that really have taught us a lot is this REVEAL HBV study that was done in Taiwan. And bear in mind that this was done mostly in the 1990s and in the early 2000s, before we had widespread availability of hepatitis B antivirals. So this was the last big natural history study that you can do. Now with all these treatments, you can't really do natural history and just watch people. So they went out to the community and they recruited initially some 200,000 people. The purpose of the study wasn't hepatitis B. It was really studying diabetes, studying cancers, But then they realized that, oh, we can actually use the same database to study hepatitis B. So among that cohort, about 3,600 were hepatitis B positive, but hepatitis C negative. They were mostly interested in adults, and so the entry age was at least 30, and the maximum was 65, with the mean age at entry of about 43. Majority of these people were men because they were recruited from the community and not from liver clinics. Many of them were antigen negative. Most of them had normal liver enzyme, and only 2% of them had cirrhosis. They were followed for a mean of about 12 years, every 6 to 12 months. And the most important thing that we learned was the importance of the virus, particularly virus replication. So what they showed was that the baseline serum HBV DNA, the higher it is, the more likely people are going to have liver cancer over 12, 13 years of follow-up. This was also true when they looked at baseline HBV DNA as a predictor of cirrhosis, of liver complications, of liver-related mortality. So based on that, they came up with a prediction model, which is fairly simple. You look at gender, age, ALT, antigen status, and HBV DNA, and you get a number assigned to it, and the total score is 0 to 17, and based on that, you can read out from a nomogram the 10-year predicted risk of HCC. This was subsequently validated in 3 Asian liver centers using 3 other cohorts of patients. The problem is that you can see that even though in all the review studies they concluded that HBV DNA is the most important predictor of cancer and mortality, you can see that this patient who has the highest HBV DNA is actually predicted to have the lowest risk of cancer. And this is because, yes, the virus is important, but there are other factors. And the reason why this patient has a lower risk of cancer is because she's a woman and she's young. Okay? So that tells us that we do need to think of other things. And because this was derived from a community cohort, the performance is not as good in patients with cirrhosis, and it's not as discriminatory in patients with lower levels of DNA. And if you have patients who are younger, 25-year-old or 70-year-old, it's not really applicable. It's also not been validated outside Asia in people with adult acquired hepatitis B infection or in those infected with other genotypes other than B or C. So we got to find other better tools. Again, in the last 10 years, people have gone back to, well, what about hepatitis B surface antigen? After all, this was the first marker that we know about hepatitis B. And we've always ignored hepatitis B surface antigen. We focus, because every time there's something new, we focus on antigen, we focus on DNA, we focus on all these molecular genotyping and variants. But 10, 15 years ago, people said, let's just go back to the origin, which is hepatitis B surface antigen. You know that this is the complete virus. You have the envelope, you have the nucleocapsid, and then you have the DNA and the DNA polymerase. Hepatitis B virus is unique because it makes a lot of empty particles. These empty particles contain a surface antigen. There's no core particle, there's no DNA, so they're not truly infectious. Remember, back in the late 1970s, when we made plasma-derived vaccine, that was to actually take plasma from people chronically infected and isolate these empty particles to make vaccines. So they're not infectious. They exceed in abundance more than 1,000 to 1 compared to the complete virions. They actually, what do they really represent? Well, obviously, if there's surface antigen, there's messenger RNA that can make the viral protein. And if there's messenger RNA, there must be the virus DNA. And there is a good correlation between serum HBs antigen level and a covalently closed circular DNA in the liver itself. So that started off a lot of people trying to develop quantitative assays for surface antigen. And one of the things that people have tried to do is, well, with all these transitions of patients from one phase of hepatitis B to another, if you see the patient once, sometimes it is difficult to know whether you can accurately classify the patient, because it may be that they're in the active phase, but you catch them on a day in which the liver disease is quiescent. So one of these studies show that the surface antigen is more stable than DNA. And if you actually express surface antigen to hepatitis B virus DNA, you're better able to differentiate the inactive carriers from those with e antigen negative chronic hepatitis, because the DNA is low, but the surface antigen remains somewhat high. More importantly, though, in the last few years, people have utilized quantitative surface antigen to predict outcomes, risk of cancer, risk of liver-related mortality. And this is particularly striking in people with low viral level. In patients with high viral level, whether your surface antigen level is high or low, it doesn't really matter. But in patients with lower virus level, the people with high surface antigen level have a much higher risk of developing liver cancer. So this is just helping us refine our prediction models so that we are better able to categorize them. Well, nothing really matters if we can't treat. So you predict someone is going to have high risk of liver cancer, and all you can do is to make them worry. Well, the good news is that we do have treatment, and we have treatment that's relatively safe, effective, in controlling the virus, but also in reversing cirrhosis and preventing clinical outcomes. It's not as exciting as hepatitis C. With hepatitis C, I mean, you have to update your slide every 2 weeks. This, you only need to update it every 5 years. Actually, the last time we had any new drug was 2008, and there's really nothing on the horizon. But it's making a comeback. It's making a comeback because if you actually go to clinicaltrials.gov, you're now seeing a lot of new studies, a lot of phase 1, phase 2 studies, because the companies, the pharma companies have decided that if you're not a winner for hepatitis C, you're out of business, and so many of these companies are coming back to hepatitis B, which is great. So these are the treatment. We have 2 formulations of interferon, 5 oral therapies. Most of us now really focus on entecavir and tenofovir because of lower risk of drug resistance. Well, these drugs are extremely potent. So this is an interferon. It's not as strong as an antiviral, but it does have immune stimulatory effect. If you look at the oral drugs, they're very potent. Now, these are not head-to-head comparison, but still, with 1 year of treatment, you see a 5 to 6 log decline in HBV DNA within 1 year. Sometimes the patients ask me, so what does it mean these sort of virus drop from 8 log to 2 log? I say, if you put a dollar sign in front of it, and you used to have $100 million, and now you have $100 in your bank account, you would understand what it means. Now, it's not just suppressing the virus. We also want to get rid of the viral proteins. So one of the endpoints we want to look at is really e antigen seroconversion. So that means that e antigen goes from positive to negative, and development of e antibody. Now, if you look at just 1 year of treatment, interferon, even though it's not a strong and antiviral compound, actually results in a higher rate of e seroconversion. And this is still something we try to understand. And we keep saying, oh, it's because it has some immunostimulatory effect, but we don't completely understand what it does. What we do see is that it does result in a high rate of E seroconversion compared to the oral antivirals. Now, the people who are supporters of oral antivirals always say, but you know, the oral antivirals are so simple, you don't stop at 1 year, you continue treatment. So we do have data up to 4 or 5 years. In the 4 or 5 years of treatment, continuous treatment, you get roughly 40, at most 50% of patients achieving E seroconversion. Now that's important because if you think of E seroconversion as an endpoint for stopping treatment, and you only get 40, 50% after 5 years of treatment, that means that after 5 years, more than half of your patients still need to be on treatment. And this is where, cost and when you start treatment come into play. Because we're not talking about 8 weeks treatment like hepatitis C, 12 weeks treatment like hepatitis C. We're talking about 5 years, 10 years, and in many patients, lifelong treatment. The ultimate goal, this is where I write the American Liver Association guidelines for hepatitis B. The European Liver Association guidelines say, you know, you Americans, well, actually, I'm not an American. I'm still sort of a foreigner. They basically criticize you not really aiming high enough because we said that, surface antigen loss is an ideal goal, but it's so difficult to accomplish that you've got to have a more practical goal. We've got to talk about viral suppression, e antigen seroconversion. The European Liver Association guidelines say, well, we only aim for one thing, which is S antigen loss. Yeah, it's good. I would like to get a gold medal in the Olympic Games. But at my age, what is the chance? So if you look at how good treatment is in getting rid of S antigen, for e-antigen positive patients, if you get 1 year of interferon treatment and we follow you for the next 3 to 4 years, about 11% S antigen loss. Pretty good. But that's only if you are infected with genotype A. If you're infected with genotype B and C, that's like 2%, 3%. Okay? With the oral antivirals, even if you treat patients for 4 or 5 years, well, tenofovir seems to be higher, but this is based on one single study, 10%. The others are like 2%, 3%. Okay, among the e-antigen negative patients, it's just as dismal. Yes, this is the ideal goal, but if the ideal goal cannot be reached, I don't know how useful it is. The good news, though, is maybe you don't need to necessarily get rid of e-antigen and S antigen as long as you can keep the virus suppressed. And this is very important data because when I was a medical student, I was taught that cirrhosis is irreversible. You got all this scar tissue, you get all these nodule formation, you do. But we now recognize that this is not true. When alcoholics drink and they come to you with alcoholic hepatitis, bilirubin of 25 and ascites, if they stop drinking, some of the patients, when you see them back in clinic, you can hardly recognize them. They look very normal. And we know that with hepatitis B and C, it's the same thing. You suppress the virus for long enough, it's not just the inflammation that's being suppressed, the fibrosis actually gets remodeled. This is an important study. This is the tenofovir phase 3 trial. Bless those patients who agreed to 3 liver biopsies, baseline, year 1, and year 5. And they had a very large number of patients. 54% of patients actually agreed to all 3 biopsies. Okay, maybe there was a little bit of coercion, I don't know. But anyway, what you can see is that in red are the patients with cirrhosis. At entry, more than 20% had cirrhosis. By year 5, less than 10%. So out of 96% who had cirrhosis at baseline, 71 of them, the fibrosis scoring had dropped such that they are no longer read as having cirrhosis. And we now understand that, yes, cirrhosis can be reversed, not in everyone, but in some. And antiviral treatment can also prevent adverse clinical outcome. So this is a landmark clinical study done in Asia where they enroll patients with bridging fibrosis or cirrhosis who are either e-antigen positive or with high virus DNA level. This was done more than 10 years ago now, so they were able to do a placebo-controlled trial. 2/3 of the patients randomized to the only oral antiviral available at that time, lamivudine, and 1/3 to placebo. And the study was actually terminated by the Independent Data and Safety Monitoring Board after a median of 32 months because a statistical difference, significantly different, was observed between a treated group and a control group in terms of clinical outcome, defined as increase in Child-Turk or Pew score, liver failure, or liver cancer. So it was a combined clinical outcome. But there was also a difference if you look at just cancer as an outcome. Not as dramatic because there are less events. Now, still the lamivudine group, 5% versus the placebo group, 10%, with a P of 0.047. Now, if you exclude the patients diagnosed with liver cancer in the first year, then it just falls shy of being significant. But still, these are very, very important data to show that if you suppress the virus, you do reduce inflammation, you can reverse fibrosis, you can prevent patients from getting to liver failure and liver cancer. The liver cancer part is not as sort of definitive. You reduce the risk, but you don't completely prevent that risk. So we have great treatment. The big question is, do we treat everyone? And if not, how do we decide who to treat and when to start patients on treatment? So there will be always a group that is easy. The patients who are referred to a liver transplant clinic with ascites, they're about to die in front of your eyes. You're going to treat them. You're not going to wait. And then there are patients in whom you feel that you can monitor. These are very young people, low-level virus, normal liver enzyme. The world is never black and white, so the gray is always bigger. And then you have to really figure out what is the risk of this patient developing cirrhosis, liver failure, and liver cancer, in the next 10 or in the next 20 years. I always tell my patient, you know, we doctors are really like the weatherman, except that I hope that we're better than the weatherman. It's easy to sort of predict, is this patient going to die of liver failure in 6 months? Most of us in this room, non-hepatologists, you should be able to do that. But the patients actually want you to predict, what's my risk 10 years from now? And that becomes a lot more difficult. So the clear-cut cases in which we'll start treatment will be the patients with life-threatening liver disease, acute liver failure, decompensated cirrhosis. We'll also not hesitate to treat those at high risk of liver failure, liver cancer in the near future. And these will be the patients with compensated cirrhosis and high levels of DNA. Those are sort of easy. Now, oncologists might disagree, but we hepatologists all agree that surface antigen positive patients will be starting immunosuppressive therapy, particularly cancer chemotherapy. They should all be covered with antiviral because there is no reason in 2014 that your patient would survive lymphoma just to die of reactivation of hepatitis B. It is so preventable. I have unfortunately known of too many people who've survived the cancer but die of reactivation of hepatitis B. So I'm on a mission to prevent that from happening. So the rest is really the non-cirrhotics who may be at high risk of progressive liver disease in the future. And that's where it is difficult. So when we wrote the guidelines, we said it's okay, it's easy. Treat these folks, treat these folks. Watch these and watch these. But with the review data showing that high-level virus is a bad thing, some people have actually accused me, you're a murderer. You said not to treat these patients in your guidelines. And you're killing them because they're going to develop liver cancer. My response is always, the guidelines are guidelines. I'm not so powerful to tell you that if you decide that this patient needs to be treated, I would put you into jail. So you can do whatever you want. Plus, the guidelines state very clearly, everyone in whom you decide treatment is not warranted at this time should be observed, because we know that a year later, this patient may have moved to a different state. Is when you tell the patient, you're fine, I don't ever need to see you again, bye-bye, that's when you get into trouble. But if you continue to monitor the patients, you should be able to treat them at a later stage. And yes, the dilemma is always, even though we know that cancer risk is highest when patients are in this stage, but it can occur at any different stage. And that's the reason why having the prediction models is important. But we don't have perfect models yet. So we still need to continue to work on that. Now, some of my colleagues would say, why do we need to struggle? Because if you treat everyone, then you cover everyone, right? Well, to some extent, yes. As long as you think that your patient is actually taking the treatment, and the treatment has no harm. So why not treat all patients with chronic hepatitis B now? Because everyone who's chronically infected are at risk of progressing to cirrhosis and liver cancer. Treatment can suppress the virus replication. It's been shown to improve liver histology, to decrease progression to liver failure, and to some extent, reduce that risk of liver cancer. Treatment is relatively safe, and yeah, many patients would need to be on many years of treatment. But what do you do with hypertension and diabetes? You don't treat them for 1 year and then say, I cure you of hypertension, now you can stop treatment. So that's the party that say treat everyone. But there's always the other party. So the other party asks, is treatment truly necessary for everyone? Sure, every one of us is at risk, well, every patient with chronic hepatitis B is at risk of progressing to cirrhosis and liver cancer. But not everyone is going to end up with those complications, because some of them do die of other things. Some of them do have diabetes or heart disease and die of other things. And unlike HIV, the host immune response can suppress the virus, and in some patients do a pretty good job. Suppressing the virus and keeping it at bay for years and even decades. So it's not always doomed. And while current treatment is very effective in suppressing the virus, it doesn't eradicate the virus. And long-term treatment is associated with risk of drug resistance, potential side effects, high cost, and non-adherence. Resistance is less of an issue now because we have pretty good drugs. Early on when we have lamivudine, you really have to think twice. because by year 5, almost all the patients would now be having resistant virus. But we now use mostly tenofovir and entecavir. In tenofovir, we have data up to 6 years, 0% confirmed resistance. With entecavir, with data up to 6 years, nucleoside-naive patients, 1.2% drug resistance. Well, that's in the context of clinical trials. Those of us who sort of know that clinical trials different from clinical practice would say, well, maybe it's not going to be 0, but this is not going to be 20%. So it may be less than 5%. And so the resistance is not as big of an issue. What about side effects? Well, if you use interferon, obviously there's a ton of side effects that we all know about. It has to be given as injections, flu-like side effects, fatigue, mood changes, and bone marrow suppression, as well as unmasking or exacerbating autoimmune illness. The oral antivirals are pretty safe, but not 100%. If you read the package insert, there's always a box warning, lactic acidosis, all nucleotide analogs are labeled as such. In reality, it's extremely rare with the hepatitis B oral antivirals. Adefovir and tenofovir, however, is associated with low risk of nephrotoxicity, not just impairment in renal function, but more renal tubular abnormalities with phosphate wasting, as well as Fanconi anemia. It's rare, but it can happen. And it's also been shown to decrease bone mineral density. Again, people argue exactly how common it is, because so far, most of the literature is on in HIV-infected patients who are concomitantly receiving other drugs. And the literature on HBV mono-infected patients is really not as robust. Now, tabifidine, which I have only prescribed in one patient, is not a great drug because it's similar to lamivudine, associated with high rate of drug resistance, but also issues of myopathy as well as peripheral neuropathy. So there are some side effects. The good drugs aren't as bad. Well, what about cost? Well, cost is now right on our face every day when I'm in clinic, because 2/3 of my patients have hepatitis C, so every day we talk about cost. And hepatitis B drugs are really cheap compared to hepatitis C drugs. So the most recently approved hepatitis C drug, Havani, is $11.25 per pill, okay? $1,125 per pill. You look at this, okay, brand name entecavir just got off on patent. Brand name is $48 a day. So 1 year is only $17,500 per year. But I've just mentioned, the problem with hepatitis B is we're not treating them for 8 or 12 weeks. We're treating them for 5 years, 10 years, and sometimes for life. So how much is 10 years? Well, 10 years, this is about 24 weeks of Havani. I can treat 2 Hep C patients for 12 weeks now, okay? So you have to take into the context of the entire cost of treatment and not how much it costs every day. The problem is the generic is not that much cheaper, although I was assured that, well, just wait another 6 months. There are more companies making generic, and then it will come down. I don't know by how much. Tenofovir is a little cheaper because it's also used for HIV, but still, if you're treating patients for 10 years, this is more than $100,000. So cost is an issue, and cost impacts adherence. You may not realize, but when the copay goes up, I have patients who tell me, you showed me that my virus has been undetectable, so I thought I could save a little bit of money. I'm taking it every other day. I'm taking it every 3rd day. I'm a retiree. I cannot spend so much money on my medicine. And so really trying to figure out when we can stop treatment is a very important thing. And these are the current guideline recommendations: the American Liver Association, the Asian Pacific Liver Association, the European Liver Association. So all of us say, you got to treat until the patients achieve E seroconversion, continue treatment for another 6 or 12 months to get consolidation before you stop. So 40 to 50% achieve E seroconversion after 5 years. So this means most of the patients are going to go on beyond 5 years. Okay, for e-antigen negative patients, we treat until S antigen loss. I told you, 2 to 3% after 5 years. So you're basically condemning everyone to lifelong treatment using these guidelines. Well, I'm guilty of writing them, but I don't know what else I can say. And if they have cirrhosis to begin with, then we say don't you dare to stop, because if you stop and the virus comes back and the patient have a flare, then you become a murderer. So we got to really figure out a better way, and that means that we need better treatment. And this is just one slide to show adherence. So this is a paper that I published with a fellow, and we obtained data from the pharmacy claims database. And this is really looking at, so this group are the patients who have drugs in their hands only less than 80% of the time. So if you give people 30 days supply, they're supposed to come back for 11 refills. If they don't come back for a refill, no matter what they tell you, they cannot be taking the medicine. They don't have it at home. And 20% of the patients have less than 80% adherence. We did another study in which an innocent fellow did a survey on the patients, and then when they walk into the clinic, I asked them the same question, I document in the notes, and the fellow compared the answer that they get in the survey with the answer that I got. So of course the patients tell me, Dr. Locke, I never miss a single day. You've reinforced how important it is, and I don't dare to miss a single day. But they tell the fellow, you know, I missed 3 days, but don't you dare tell Dr. Locke. So, are they light down the tunnel? Yes, we have a lot of new drugs. This is complicated hepatitis B virus life cycle, and I'm not going to go through that, except to say that the oral antivirus really stop the reverse transcription of the pregenomic virus RNA into the DNA and synthesis of a second-strand DNA. But there are multiple steps in the HBV life cycle that we are not really impacting right now. So there are opportunities. We have now identified new targets, including receptor blockade, epigenetic modifications of the cccDNA transcription, capsid assembly inhibitors, antisense to block HBV transcription, as well as some immunotherapy, couple of antiviral therapy to stimulate T-cell response and block the negative regulatory pathways. This is really not sort of just fancy science fiction. If you go to clinicaltrials.gov, you'll actually find some of these in phase 1 and phase 2 clinical trials. And so I'm hopeful that we'll be hearing more, and some of them will pan out. Perhaps the most exciting is the cloning and the identification of the entry receptor, which is published in first 2012. And very quickly, this allows for screening of compounds that can block virus entry. And already, there's one compound, Mercudex, which is now in phase 2B clinical trial. And I've seen the data. It's not as exciting for hepatitis B, but it's extremely exciting for hepatitis delta. It looks pretty good for delta. But suppressing the virus alone may not be enough, because if you stop the treatment, the virus might come back unless you're able to boost the immune response. And there are multiple pathways, but this is really a very nice cartoon from Antonio Bertoletti and Carlo Ferrari, and they basically say it has to be a multi-pronged approach. First, you need to suppress the virus. Then you need to decrease the circulating S antigen because this actually causes an inhibitory inhibition on the immune response. Then you have to have multiple pathways of attacking it. For the last 20 years, there have been perhaps 30, 50 studies trying to stimulate the host immune response to control the virus, and all of them have ended up in failure. But people are not stopping. And this is one example. This is actually also being tested in humans, but I'm showing you the data on 2 chimpanzees, a couple of chimpanzees. And this is an oral agonist of toll-like receptor 7. And this is a chimpanzee that was given the toll-like receptor. And what you can see is that suppression of HBV DNA, not only in the blood, but also in the liver. And guess what? When you stop treatment, the virus suppression stays for quite a while. So this is being carried out in clinical trials. For a while, we stopped because of some safety concern, but that's been cleared by the FDA. And now the clinical trials in humans have been revived. So what I have done in the last 40, 50 minutes is to summarize some of the progress that we have made. Decline in the incidence of hepatitis B infection through infection control measures and vaccination, hepatitis B vaccination, being able to prevent not just infection but also cancer. Predictive models for cirrhosis and cancer, we still need to work a better job and refining it. Availability of safe and effective antiviral drugs that can reverse cirrhosis and prevent clinical outcomes. But there's still problems. Limited coverage of hepatitis B vaccine, particularly the birth dose. Global burden of chronic hepatitis B infection is only minimally changed. Prediction models of limited generalizability and not sort of fine enough. And certainly, we're not able to achieve our eradication or even long-term suppression with finite duration of treatment. And perhaps an even bigger issue is the gap between what we can do and what is actually being done. This is an estimate of the number of people in the U.S. that are chronically infected and the number of people that are being treated. So unless we raise awareness, we make the diagnosis, we link people to care, and we decide who needs to be put on treatment and get those people treated, it doesn't matter what we have. It's not going to have an impact. So after all this, there's still opportunities for hepatitis B research, and I do not need to plan my retirement yet. But had I listened to people's advice and chosen hepatitis C, the end is actually nearer. Thank you.
Thanks so much for a really nice talk. Maybe it's not on. You know, it's not on.
It's not on.
Yeah. Okay, I have to yell. So,
maybe just, oh, there we go. So you may not have to have a choice, meaning maybe you can go after both prevention as well as treatment. But if you look at kind of where the best bang for your buck is, where would you put your money? Because I mean, you have an effective vaccine. Is it really just kind of worldwide vaccination programs? Or is it pursuing these very expensive drugs? Because again, every new drug, the drug company is going to charge $1,000 a pill, as we see. So where do you want to put your efforts?
Well, I mean, you're talking like Bill Gates, who prefer prevention. And of course, prevention is always better than cure. But then what do you do with the hundreds of millions of people who are chronically infected? You tell them, don't worry. If your generation died off, there'll be no more hepatitis B. I can't do that. Yes, I mean, I don't want babies to be infected, but I can't talk to people who come to my clinic and say, we're not going to do anything for you. Because once you die, then problem will be solved. So there are enough people that are chronically infected that we still need to do something. And does every pill need to be $1,000 a day? I think that there are a lot of papers coming out now. I mean, how much does it cost to make a pill? And we all know how much it costs to make a pill. And the drug companies argue that it's really the research and development. It's not the research and development. It's what the market can bear. Now, tonight, I'll show you a slide on hepatitis C drug, because everyone is talking about how expensive it is. And Gilead, that makes these drugs, said, we have a heart, we have a soul. We're not just greedy drug companies. Look at what we did with Egypt. So Egypt has the highest prevalence of hepatitis C in the world. Among adults, as much as 20 to 40%, the older adults are infected with chronic hepatitis C. It's a major, major disaster in Egypt. And the Egyptian government worked out a deal with Gilead such that they're going to get for 12 weeks, Sovaldi, $900. You can't even get one pill. They get 84 pills for $900. So you say, that's wonderful. What happened on Monday? I got an urgent phone call from CDC. Can you join us on a conference call with CDC, WHO, and the folks in Egypt? They are going to receive the first shipment of Sovaldi, the low-cost Sovaldi. It's only enough to treat 50,000 Egyptians. And you say, well, if your clinic gets 50,000 low-cost drugs for treating 50,000 people, you'll be very happy. But for a whole country that has such a high prevalence, 50,000 isn't enough. They said, well, obviously we need to prioritize because we don't know when the second batch is going to arrive. Okay? And they said, well, we're going to have all these models to figure out who has cirrhosis. And if you're not having cirrhosis, wait. But we estimate we have about 250 to 300,000 people with Hep C cirrhosis now. There are only enough for 50,000 people. So of that 250,000 to 300,000, can you advise us how to select that 50,000? We don't want lottery. But you have cirrhosis and you still need to be selected. So do you select the sickest who should be dying in 3 months? Maybe it's too late now. Do you select the earlier ones? Do you select the middle ones? So we gave them some advice. I don't know whether I gave them the right advice. Sometimes it's very scary. I mean, people call you on the spur, on a phone call, you give this advice, and then sit down and say, oh my God, I'm not so sure.
What advice did you give?
So they actually do a good job with doing various screening. So they said that the majority of our cirrhotics have endoscopy. And we say, okay, if they're known to have viruses, that's one marker of more advanced disease. But even within the cirrhotics, you can look at the platelet count. So he said, look at the platelet count, look at the AST to ALT ratio. And there was actually, unfortunately, a paper that came out in Gut, it's actually online only, that specifically look at patients with compensated cirrhosis and predict who's going to decompensate. So they come up with a model which really look at just age, AST, ALT, platelet, which is very simple. It's not been validated by another study. So we said to them, look, I mean, those are things that you have, because when you give this type of advice, one of the tricky things is you cannot make it too complicated. You have to use criteria that you have data on pretty much everyone, because otherwise, I mean, it doesn't work. So that's basically what we gave. So use this paper, or simply you can always use some APRI, although APRI is mostly to sort of differentiate cirrhosis from no cirrhosis, but not so much in predicting decompensation. Now, APRI is AST platelet ratio index, which we invented in 2003. I wish I had applied for a patent because it's been cited so many times.
Canada, we have really good studies of how to get countries to know the efficacy of the monovalent vaccine versus polyvalent vaccine.
Well, the monovalent vaccine and the monovalent vaccine, there has been tons of data, and it works extremely well. The pentavalent vaccine, there are also some data, perhaps not as robust. And the incorporation of hepatitis B vaccine into pentavalent vaccine is simply for simplicity. In countries where resources are limited, sometimes it's not just the cost of the vaccine, but the delivery, getting the kids to come to clinics where they can be vaccinated. So if you can bundle them, you get a higher uptake rate. So I understand that. But I mean, with some countries where the moms can be carriers, and if a high prevalence of the moms are carriers, saying that your baby should wait until 2 months old to be vaccinated means that some of them are going to get infected and go on to chronic infection before they get the first dose of pentavalent vaccine, and that's the problem. And these countries rely on Gavi to supply them with the low-cost vaccine. So there has been a letter signed by 100 associations appealing to Gavi, please don't be stupid.
Elena, thanks so much. Really